morning, everyone. This is about a 59-year-old female, short-statured, obese, presented with both knee pain, more on the left side, and was diagnosed as osteoarthritis both knee. And as usual, patient refused surgery. So she came after 1 month to me, presenting more pain on the left side. Now at present the pain is more just below the knee. So we took a full leg x-ray and we don't find anything suspicious, so she was treated conservatively and she was sent back. So 15 days later, so there was a severe pain and not able to walk. There was no fall, but there was one history of a click followed by a severe pain. So she presented to us with this situation. So we diagnosed as a pathological fracture because there was no fall or any injury. So what is the further course of action?
So the first question is, Amar, how would you investigate this patient?
So as I mentioned before, this problem is so common here in India that she needs a metabolic bone workup for sure, she obviously probably needs vitamin D. I agree with that, and maybe even bisphosphonate treatment. But yeah, I mean, listen, you can decide based on the severity of your knee problem whether you do this with a primary knee and a long stem, or whether you just treat the fracture first and come back later and do the total knee. That's a decision that you can make, but you could do it either way.
Mahesh, how would you approach this?
Looks a little bit unusual for a stress fracture. The stress fracture that we commonly see is failure in varus on the tibial side. Yeah. Here the failure seems to be on the anterior cortex, so I'll be a little bit suspicious to make that diagnosis of a stress fracture without further investigations.
What investigations would you want?
Definitely would consider an MRI scan to understand if there is a lesion in the tibial shaft area.
Would you get a BMD done?
No, not normally.
Not normally. Dan, anything that you would...
No, I agree with the points. You see more stress fractures than we do of the tibia. I agree with Amar about that. Having said that, the ones I've seen do not usually follow this pattern. Right. It's a short oblique one. It looks like the anterior cortex. So I'd image the patient, have a metabolic workup. If that all comes back negative, then you can manage the fracture.
Right. So tell us what you did.
So we staged all the parameters were
Rajesh, you have a point?
Yeah, so for us also, this is a very unusual.
It is unusual,
very
for
unusual
sure.
Stress fracture.
Yeah.
And I'm just thinking whether there is something in the hip or what else is going on here.
Yeah, exactly.
So
did you get a scanogram done for this patient?
So no, sir, we did a CT scan to know, but...
No, did you get a scanogram, a full-length X-ray for the hips?
We didn't have an option of having a scanogram.
All right. Yeah.
But we did a CT scan to know whether there is any pathological lesions at that site because the MR was not accessible to my hospital.
Right.
So what is the BMI of the patient? That causes a lot of issues. Short patient with a varus deformity, they can have a lower fracture. I have seen fractures like this. Okay. Walking with a varus deformity, short fractures. Yeah, but, short ladies.
But typically it is a lot higher. You don't, and it's basically a medial transverse. This is an oblique, it's an anterior. It's an incomplete fracture. The posterior cortex looks kind of intact. It's the anterior one that snapped.
Yes, sir. We don't want to agree with the stress fracture, but we still wanted to do CT scan. We ruled out any pathological lesions. And this one advantage of doing a CT scan, it gave me the distance from the joint line. So I can be prepared for what, if I'm going for a long stem, what kind of the length of the long stem I can go for it. Yeah. So it was 13 centimeter from the joint line. So we have an option of 75 mm, 115 and 150 mm was the length which was available. So we went for a staged bilateral at a gap of 3 days. First I did the left. So this was the immediate post-op. So what we were able to use is the 10 mm diameter and the length was 115 mm. Beyond that it was not negotiable because of the narrow cortex in the distal femur.
Was this a 12 millimeter stem?
It's a 10 mm diameter, 115 mm length.
Okay, all right. Did you graft it or?
No, sir, I'm not grafted. I never opened that site.
Okay, you didn't. All right.
You should have plated it, I think.
How many on the panel would have plated this along with the TKR? Anyone on the panel would have done it differently? Just plate it. It's a low fracture, unusual. Anyone?
After I saw the x-ray, I would.
It's right on the edge, right? I mean,
It is.
you'd like a little more fixation down the
Yes.
tibia, for sure, another couple centimeters.
Yeah, yeah. Okay.
So
So
I allowed the patient for a toe touch. This is 15 days post-op. Patient came for suture removal, and 3 weeks later, it failed and it collapsed in varus.
Yeah.
Patient was walking on toe touch, but I was not sure whether she was obedient following the toe touch. So this is the situation which I encountered 3 weeks post-surgery.
I guess, you know, with the kind of fixation, the very point that we've been discussing, it's a very low fracture. The purchase that you have on the distal fragment is really not adequate enough. Maybe, or if you have to choose this as your option, delaying weight bearing on this would definitely be on the cards. 2 weeks toe touch. When you say toe touch, you don't really know what they're doing.
Yeah.
You don't know how much weight she is putting. And so what did you do after this?
So we are, of course,
You
I
put
involved
it-
my trauma team to go for a dual plating. They went
Okay.
for a dual plating, rigid fixation.
Okay.
And this is 2 months post-op. Patients were made to weight bear. 6 months post-op, it united.
Okay.
And this is 1 year, patient is walking comfortably.
Right. Okay.
So what are the lessons we learned is we have to strictly follow the principles of fracture fixations, even though we are a replacement surgeons. Longer stem would have been always possible, if at all. It is always use a longer stems. Additional plating could have prevented this failure.
Right. Yes, Rajesh.
Here is that, sorry, the shorter stem, you would say keep non-weight bearing and allow it to collapse, but in that case, you'll have to do a fibular osteotomy. If you had kept a shorter stem, a fibular osteotomy, non-weight bearing, it had a chance.
In this case, a fibular osteotomy, you're saying?
When you had only a short stem with
Short
you,
stem.
ideal would have been a longer stem. Ideal would have been a longer
Longer
stem.
stem.
And even if you had to ream and put a longer stem, I would have gone for that.
Yeah,
But if not, then I think keeping the patient non-weight bearing and doing that fibular osteotomy, because that is the only way you can win. You have to compress
But
that
wouldn't
fracture.
that it make more unstable being a fibular osteotomy shorter
Rajesh,
stem?
I guess he used the longest stem that is available. That is like 150, I think.